Welcome to CT Chest Review at www.ctchestreview.com. This is Dr. Bhavin Jankaria, and today I'm looking at a topic which I thought I had done earlier, but I've done only in bits and pieces. And so I'm putting this together as a small snippet that is titled What Defines an Ideal CT Scan for Diffuse Lung Diseases. Now, all my ILD talks, I have this slide where in 2018, Fleischner Society, ATS, ERS, JPS, JRS, all of them came out with criteria for what constitutes an ideal CT for ILDs and by definition all diffuse lung diseases. I added the documentation bit because this is unique to India where we are still giving out films to patients. But about 7 years later, there is no significant change. Photon counting CT has improved the spatial resolution, but it's so not available. There isn't a single PCD in India that we won't talk about it at all. So these are the various subtopics. We start with slice thickness and algorithm. Needless to say, it should be 1 millimeter or thinner with a zero point 0.5 millimeter interval. And here you can see a 1 millimeter scan. You can see the traction bronchiectasis, the tiny subtle cystic lesions here, the reticular opacities here, beautifully. If you were to see the same 1 millimeter in a soft tissue algorithm, you won't be able to make out the same detail. A 3 millimeter high resolution does allow us to understand that there is interstitial lung disease, but still reduces the detail. And a 3 millimeter soft tissue algorithm is just not good enough for anything. And typically, people still have 5 millimeter sections that they use for mediastinum. And today, I think everything should be a volume scan, whether it is a contrast study or a lung window study, and we should just be looking at volumes on our workstation. The KV and MAS should be the lowest possible, but I think clearly we need to be a little practical. So we should adjust the KV to the body habitus, use the least needed to get good images. So a patient who is overweight or has a very high BMI, let's say weighs 120 kilos, you would have to increase the kV to a certain level. But remember, when it comes to the lung, because there is such a high contrast within the lungs itself, you can still adjust the parameters reasonably well. You do need to use the lowest MA to get good quality images, but it's not easy to define these parameters because patients differ, practices differ, countries differ, scanners differ. So each individual center and its doctors and technicians should make the effort to define these parameters. With one caveat: do not sacrifice quality at the altar of low radiation technique, because that is worse than using slightly higher radiation to ensure a high quality scan. There is nothing worse than a poor quality scan that makes creates misdiagnosis or missed diagnosis or leads to a repeat study. Scans should be volume scans, and we should be even interpreting these as volume scans to make sure that we see the entire lung field from apex to base. We can keep scrolling up and down. It allows us the ability to look at coronal images. Here's the straight edge sign, beautifully seen on both sides, and the sagittal images, that allows us to see that there is an apicobasal gradient and the bases are much more involved, etc. So a volume scan on a workstation clearly allows us the ability to be more accurate with our findings and then our remarks. All scans have to be end inspiratory with good breath hold. And I have this slide that I've been using for the last 20 years showing an image which is blurred, which is expiratory, which was reported to have ground glass. I've also used it in my book. And when you look at the same image again, in good breath hold, in end inspiration, you can clearly see that this doesn't exist. This is an artifact of expiration and blurring. And while there are some reticular opacities, this ground glass doesn't exist, right? That's the important thing here. And I showed this case very earlier on in CT chest review, I guess 3.5 years ago, which I do want to show again here, simply because it proves the point, and I think we need to understand why all of this is so important. Here's a 5th February 21 scan during COVID. This was reported as reticular opacities, some ground glass, called COVID. Patient was admitted, given a rubbish cocktail of drugs. You remember those days when anything from steroids to antibiotics to remdesivir to baricitinib to God knows what was being given, and who knows what damage that has done to patients. Now, if you see the scan, the posterior wall is a little flattened, and this is you could call it mid-inspiratory, mid-expiratory. And there was a senior pulmonologist they went to after they were discharged who did not agree with this and asked for a repeat at 6 weeks. Now, 6 weeks later, and you can see how this thing is not as flattened as it was, and I'll come back to that later. But if you see here, you don't see anything even in the prone images. You could, of course, argue that all the lesions have regressed, but when you look at the expiratory scan of this patient, it is similar to the first scan of that patient, which means that all of these findings were because the scan was not an end inspiration. And you can see that the expiratory scan 6 weeks later is equivalent or looks the same as the scan from 5th Feb. Whereas an end inspiratory scan shows that there's nothing, which effectively meant the patient had a normal scan to begin with, didn't need a diagnosis of COVID, didn't need those rubbish cocktails, didn't need anything. Right? So this was a misdiagnosis, and sometimes you can have a missed diagnosis. So how do we recognize expiratory images? One is looking at the trachea. If you see a posterior concavity, then you know it's expiratory. But even if it's flat and not completely round like you see here, then that could be mid-expiratory or mid-inspiratory. The other is the look of the image. When you have an expiratory scan in a normal patient, you will have a gradient of increasing whiteness from non-dependent to dependent. And this is the same image, same time, same patient. That's the normal scan. That's what an expiratory scan looks like. And if you're not careful, you might actually land up calling this ground glass and abnormal and hypersensitivity pneumonitis, and that will be again a misdiagnosis. Expiratory images are needed, at least at the first instance that a patient comes. You may not do it for follow-up scans. We do it for all simply because it's very difficult to have, to tell our techs for this one do this, for that one do that. So it's just simpler to do the entire set for everybody. But, if you are there in attendance and you can change that, fair enough. So you do it to assess air trapping, to triage mosaic attenuation, to diagnose expiratory central airway collapse or ECAC, and for bronchial stenosis and obstruction. So I'm adding some non-diffuse lung disease stuff as well, just because, we don't practice in isolation. We look at everything in CTs. So to diagnose constrictive bronchiolitis or air trapping, you need expiratory scans. It's the definition. Air trapping, trapped lung, trapped air you can only pick up when you have two pairs or rather two scans of a pair of inspiratory, expiratory images. So look at this patient, right? Increased lucency, paucity of vessels, bronchiectasis, right middle and lower lobes remains the same on expiration. But the left lung, which is normal, shows that gradient of increasing whiteness, that we always want to see. So here it is. I mean, again, telling you left lung is normal and right lung shows air trapping. And, if this was the entire lung, you could say this is Swyer-James-McLeod syndrome. Then to triage mosaic attenuation, to differentiate among small airways disease, ILDs, and typically hypersensitivity pneumonitis and chronic thromboembolic pulmonary disease, an inspiratory-expiratory pair helps. And this is the algorithm adapted from, Kligerman's article in 2015. Nothing has changed. It pretty much remains the same. And there is a detailed snippet that I had done for this. and that's the QR code for that. Or you can just go to the table of contents and search for mosaic attenuation. And I'm going to do another post on ECAC soon. I don't know why it's been left out. But if you want to diagnose significant expiratory airway collapse, then the only way is to have inspiratory-expiratory images. And ECAC is divided into two subtypes. You have expiratory dynamic airway collapse, where the anterior wall remains the same and the posterior wall shows marked anterior concavity or bowing. Um, and then you have tracheobronchomalacia, where both the anterior and posterior walls are flattened. You see that with the right main bronchus, and here you see it with the trachea. Um, what is the significance is still debatable. It is important to report these, and then the chest physician or the pulmonologist has to figure out how relevant this is to the patient's symptoms. And then stenosis and obstruction. And I did do this one case where we talked about how the foreign bodies were missed on regular CTs. But if the radiologist had just looked at the inspiratory-expiratory scans, you can see how, again, increasing whiteness or increasing gradient of whiteness in the normal left lung and the right lung because of this betel nut in the right main bronchus shows marked expiratory air trapping, and the lung in fact expands even more because the left lung is smaller and and herniates towards the opposite side. And this is that case, and I think there are a couple of cases within that. The same is true for prone. There are a whole bunch of indications, and I have done a separate post for this, but I'm just going to quickly repeat it because even though most places now do inspiratory-expiratory scans, people somehow have this hesitancy to do prone imaging, and I don't know why. So let's just run through this. One is obviously gravity dependent densities like these. You're not sure whether these are real or not. We take a prone study, the gravity, the opacities have shifted again to the dependent area, and clearly where it was seen in the supine position is normal. But if the disease is really there, as in the scleroderma patient, then it will continue to remain in the prone images, and that's important. The other thing is identifying honeycombing. It's not clear whether there's honeycombing. This is a non-smoker, so this is not paraseptal emphysema. But in the prone study, you can see these better. And then, of course, if you use minimum IPs, you can see them even better. Look at this scan, right? You have reticular opacities, you're not sure what they are. But because you have them in the non-dependent position, this is equivalent to a prone study, so you know that, yeah, this is real. But then when you put the patient in the prone position, you've suddenly uncovered honeycombing. This is not periosteophyte lung disease because there are no osteophytes here, and there was disease elsewhere too. And you've picked up cystic change or honeycombing, which was not seen here, or maybe very subtle, but that's because of the flattened lung there. Then subtle progression. Sometimes in the supine positions, it's a little tricky. Put the patient in the prone position and see how easy it is to know that there is definite progression of disease. Sometimes it's only on the prone images that people are able to maintain good breath hold. So try what we were not able to get good breath hold, and you can see how everything is a little compressed in the basal regions. We put the patient in the prone position and everything's opened up, and now we can figure out that there's traction bronchiectasis, no honeycombing, or just a couple of cysts here, nothing else. But it is our ability to pick up things is so much better here. And then confirming a fungal ball in a cavity. We've always known that. So whenever you see soft tissue within a cavity, it's a good idea to take a prone image and make sure it's mobile, etc. And this is, of course, very rare. We did one specific case where there were these venous aneurysms, probably congenital, and we could show that with two things. One is an MR showed connection with the pulmonary vein, and then in the prone position, these completely flattened out, which means the blood was draining back into the left atrium. It was very interesting. So here's the QR code. Again, if you go to the table of contents, you'll be able to find this. And then documentation. If you are still giving films, then there should not be more than 12 images so that you have that amount of resolution to be able to make out what's going on. This is insane. This is how many? 3, 6, 9, and then 3, 6, 9. 9 nines are 81 images. I mean, seriously, even with a magnifying glass, you've already lost the resolution within the film. So it's insane. Why are we even bothering to do this? Because there's no way you can make out. I mean, you know something's abnormal in the upper lobes, but is that tuberculosis, sarcoid? Is it, there's no way to tell. It's not possible. If you're doing this and still giving soft copy images with a CD, I guess that's fine. But otherwise, this is not acceptable. The documentation also shouldn't be so narrow window. I remember it's not usually, this doesn't happen anymore because the newer generation of technologists are better trained, but in the past this is what used to be given. What we need is where you can just about see the lung pleura rib interface, just appreciate the difference here. That's your standard a window width and level setting. So that's it. That's the technique. I think it's very important, and all of you who practice chest medicine and chest radiology, who read CT scans, and pulmonologists who have to keep seeing scans done from all over. You have to push the radiologists into making sure they give you great quality scans. And radiologists, obviously, you need to make sure that you create great quality scans, right? Thank you so much for listening to me. And I have this slide here because I'd given this as a talk also I think a week ago. Now that'd be a good idea to show this. Take care. Bye bye.